Morning, everybody. We are going to talk about nothing to disclose, concern significant others and family interventions. My goal for this talk really is just to kind of go over some core concepts of family intervention and how they can be incorporated as standards of care, regardless of your role. Discuss the importance of engaging with concerned significant others whenever you're working with somebody with a substance use disorder, and identify some sort of concrete things that you can do. So even if you're not trained in any kind of family intervention, the talk today is really just to give you some concrete steps as to how to begin to work with concerned significant others and the family members that are identified by the patients you're working with. So first thing, let's define what is a family, because we talk about family therapy a lot, but it's good to kind of outline what this term really means. So family is something that is determined by the patient. So it really just means anybody in their social network where there are current enduring ties. So they define who these folks are. It does not have to be blood relatives or parents or partners. When you ask the question, who is most important to you in your life right now, whatever they respond, we can put into the category of family, or a lot of the literature calls them CSOs, which means concerned significant others. So it's somebody in their life who they identify can be involved in their care and who cares about them. It can be someone that they live with. It just has to be someone that they identify as being important to them in their current life. So you can even engage with CSOs that might not live in the same state. So we can use phone, we can use different technologies to increase that communication. It's about the relationship that they have with that person, not necessarily their physical proximity. Some people that you can consider, if they can't come up with anyone, is sort of asking, could it be people like parents, or grandparents or guardians, people that are a romantic partner or spouse, in-laws, siblings. We're going to label children here not as young children, but as adult children. So if they have adult children in their life that want to be involved in their parents' care, so 18 and above, then we could include them as a CSO for the identified patient. Godparents, extended family, friends, even colleagues and coworkers we've engaged with. So it really is however the patient identifies. But the reason why it's important to always be thinking, how can you include CSOs in the care that you're providing for these folks, is because addiction doesn't just affect the individual, it really affects the entire family system. So keeping in mind again that we're defining family very loosely, but that entire social network is going to be affected by the one individual's addictive behaviors, or set of addictive behaviors. It puts a great deal of stress on these interpersonal relationships, and that can be very frightening, it can be very unsettling, it can cause a lot of anger, it can cause a lot of hurt, and typically by the time somebody enters treatment, their social network, their family system has already done a great deal of things to try to help that individual. And so a lot of times the family system is very taxed, if not already had some pretty significant ruptures occur before they've even entered treatment. So keeping in mind that it's really important to engage with those folks to try to provide support, education, and to help improve how the entire family system is really coping to improve the equilibrium, because the system itself is what's going to support that individual in long-term recovery. In fact, we know that the number one reason why people relapse, even after they've achieved and sustained abstinence for a while, are interpersonal stressors. So things that have occurred in interpersonal fights, losses, separations, things that are going on in that social network, that's the number one reason why people will relapse. So making sure that we are really treating the entire family or that entire system is only going to improve how the individual you're treating does in the intervention that you're providing, but also their long-term prognosis. We also know that addiction can really become sort of the elephant in the room, or the focus for that entire family system, and create a largely negative atmosphere. So all of the interactions, again, by the time the identified patient enters treatment, there's typically a lot of anger, resentment, hostility, guilt, shame, anxiety, all kinds of negative emotions that are predominant and that are the main experiences for everyone in that system. And it can include depression type symptoms, or grief, guilt, shame, embarrassment, helplessness, hopelessness. And this is both sides of the fence, the identified patient and the family members themselves. Another variable that we want to keep in mind, and why it's so important to be engaging with concerned significant others, is we know that addiction within a family system very much affects the children that are in that system, the children that are in that household, and we know that those children are particularly vulnerable and going to be affected. And in fact, the ACE study, which is this pyramid down at the bottom, which looked at the impact of adverse childhood experiences on the sort of long-term trajectory of individuals that experience some of those ACEs, or adverse childhood experiences, exposure to addictive behavior being one of those things, is that they are highly vulnerable to abuse and neglect. That in fact, homes that have substance abuse are much more likely to interrupt a child's normal development, which is going to lead to higher risk for physical, mental, emotional problems, more likely to have school disruption, more likely to have diagnoses of learning disabilities, to skip school, to be expelled from school, and have all kinds of emotional and behavioral impairments. They are likely to have mood or attentional or even executive functioning conditions, and they are 4 times more likely to then go on to develop a substance use disorder themselves. So not by engaging with concerned significant others to support the entire family system, not only are we helping the identified patient, we're also helping the children in their life. And we are hopefully starting to move in the direction of preventing our community continuing to have generation after generation of substance use disorder. So keep in mind that you might not even be working directly with those children, but by engaging with the social network, by providing even just resources and education, that might go a long way to improving the health of the entire system. And I've said this repeatedly, but understanding that none of us really exist in isolation, that we really depend on the kindness of those around us. And that's because our social networks really are a system. So really the whole is greater than the sum of its parts, that the system has particular dynamics and a particular identity that only is present or functions with all of those members combined. So people might present differently by themselves than they do in their social network, which is another reason why it's really important to be engaging that network, because you might not be getting the full picture. Our patient population historically doesn't have a lot of trust in behavioral health or medical providers. There tends to be some issues with wanting to sort of give us the full picture, and there's lots of valid reasons for that. So when we engage the family system, we might be getting more information that can assist that patient. We might be able to identify what is actually hurting them within that family dynamic, and be able to make some targeted recommendations to help improve that dynamic. Or we're able to identify what really helps in that relationship and be able to bolster or strengthen those things. But if we're not looking at this particular aspect of their addictive process, then we could be missing out a big piece of the puzzle. We also know that patterns repeat across generations. So like we saw in the previous slide, that children that are raised in a household with substance use disorder are 4 times more likely to develop a substance use disorder themselves. We could say the same, similar patterns with trauma exposure, with all kinds of different conditions. So we see these patterns really can repeat across generations. So grandma might have the same problem that granddaughter has. And so by engaging the entire system, we can sort of see those patterns and help to normalize it for the patient that we're working with. We can help to take a little bit of the stigma and the self-blame off of the individual that we're treating by saying, you know what, you kind of learned some of this behavior. And let's talk about how you could unlearn it. So we could even get some engagement there. We also know that long-term recovery, or really any health variable, require the balance of connection and individuation. So being able to be connected to a social network in a healthy way, to be able to get social support, you know, is one of the most protective factors, regardless of what condition we're trying to treat, whether it's from anxiety to depression to opiate use disorder. Being connected to healthy social supports is hugely protective. But we also need to be supporting things like healthy boundaries, things that support healthy individuation. That just because your family does it this way, or the people in your life do it this way, it doesn't mean that you have to do it this way. So being able to strike that balance is a really important part of a recovery journey for most people. And so we have to be engaging the system to even understand where that balance exists and how to intervene. And we know that individual symptoms frequently can have meaning within family systems. So unfortunately, when patients do enter treatment, they really are wanting to make some positive changes in their behavior. And on the surface, the individuals in their lives might absolutely be in support of that or want that. But what's going on underneath is sort of an unspoken dynamic that might unintentionally sabotage that person's recovery. And so sometimes just reaching out and providing some education, particularly around MAT, medication-assisted interventions, what they mean, can be hugely impactful. I can't tell you the number of times that we have patients come in really ready to start on Suboxone, and then they come in a month or two later and say, I need to get off this because my family member, my loved one, my partner doesn't want me to stay addicted, doesn't want me to be addicted to this thing. And so just being able to engage that family member and give them some education that what we're talking about is not addiction. That dependence is different than addiction, right? Being able to explain those things can be hugely impactful in terms of the person's engagement and retention in treatment. So we really have to think about our work as substance use professionals as looking at the entire system, not just the individual that's in front of us, because we know that substance use is developed and maintained within that system. It's going to reflect those difficulties, that it could be exacerbated, their relapse risk or their current use could be exacerbated by family interactions. We know that this is another interesting fact, that adults with substance use disorder are 5 times more likely to live with parents or family members from their family of origin, so grandparents, aunts, uncles. And a lot of this has to do with the fact that some of their functional areas like employment and housing have been eroded in the later end of their disease, where they sort of lost those things, and they've become dependent or had to move back in with people who maybe raised them. Now, what are the implications of that? So now I've got a 42-year-old or a 50-year-old who's now back living with mom and dad, or the grandparents that might have been part of raising them. Well, even though they're 50, those family dynamics that were there when they were 15 are going to show right back up. And so we have to be aware of that and how that could potentially hinder that person's recovery prospects. We also know that individuals tend to seek treatment at the behest or even coercion of family members. And so making sure that we're engaging with those folks is going to help protect the individual and improve healthy communication. It's also going to help with the individual's engagement, because we can start to separate, well, I'm only here because so-and-so is making me come, or I have to come for X number of sessions, or they won't let me stay there anymore. We can start to separate that and help them see how this could be a win-win for everybody. We already talked about how families can sabotage patients' treatment, and that sobriety is a change. So families are like an engine, and they will evolve over time to accommodate an individual's use disorder. Even as destructive as those behaviors are, the family system will accommodate it. And so then when we shift into a change like sobriety, the system might not have the skills in place to accommodate that new change. So that's what's really important, particularly at periods where they're doing a sobriety sample or where they're starting to really decrease their use, that we're engaging with the people that they live with or the people that are really close to them, to sort of talk that through and support them in understanding what might this change do to your relationship. And it's really common that the folks that we're trying to connect with in their social network, that they themselves have use issues. It might not be the exact substance use disorder that we're treating, but typically the folks in that network also have some other substance use or abuse pattern that's going on. And so we could really be tapping into some sticky stuff if we don't think about bringing them in. We also know that this is extremely important when we're treating women. Women are socialized to be highly connected to their families, particularly their primary family and children. And so making sure that we are including concerned significant others in any treatment plan we put together for women is very important. And a lot of research supports that, that we need to be engaging with those. And it's also necessary when treating adolescents, that we should never be treating somebody under the age of 18, or I would really say under the age of like 22, that are in that transitional age period without engaging with their concerned significant others. And all of the treatment recommendations would say that we're really going to be dealing with some sticky family dynamics, whether we like it or not. And so bringing in the parents, the people that are supporting that adolescent are really, really important. So what are some of the barriers that we hit? Well, there's a number. There's a reason why this isn't just the standard of care across the country. There's client barriers. So a lot of folks that enter into treatment, they feel tremendous stigma, guilt and shame, particularly over any wrongs. Addiction will cause people to change pretty significantly, where they're stealing or lying or hurting people in their life that they would never normally do if they weren't experiencing active addiction. So they have a lot of guilt and shame over some of those past behaviors, and might not want to bring people in their life to sort of face or work through some of that. They might believe that it's not going to be helpful. They might have a viewpoint of sort of like, in America, we're very individualistic. So they say, well, it's my problem. I should be able to handle this. I want to get better. I want to get clean on my own, and then I'll go and talk to my family, or then I'll go and make amends. And that's not necessarily the best course for folks. So helping to explain to them that really, none of us get better in isolation. If we think about any time we've tried to change behavior, how successful have we been when we've done it completely by ourselves versus when we've had neighbors and friends and colleagues and people in our life to support us, to cheerlead for us, and definitely to encourage us with those really difficult changes. There could be something that they don't want their family to know about, particularly if they've convinced their family that they've stopped using, but they're actually still using. And so being able to negotiate with the patient that what information exactly you would share with the CSO and what information you wouldn't, and that they have control over that you don't need to give their loved ones their UA results, but maybe you want to bring their loved ones in to talk through an argument that they just had, or particularly to provide them education about the medications that they're taking, so that they're not getting all of this misinformation when they come home. So being very clear about what you share and what you don't share. There's also family barriers, because the patients feel a lot of guilt and shame about past wrongs. So do the people in their life. Because like I said, there's usually been multiple attempts to help that person stop using or control their use behavior before they ever enter treatment. And so the family members themselves might feel tremendous guilt or shame that they have failed, that they were unable to do anything or to intervene. And so that could be a big barrier. Frustration over past recovery attempts that have failed, that powerless or inability to help themselves, and then the client not inviting them or refusing to have them be involved. We also know that there's barriers on our end, that we come to the table with a fair amount of misinformation about some of this. So we might feel like, well, I've not been trained in family therapy, or I'm not a therapist, or I don't know how to do this, so I might feel unqualified. And that might be true if we're talking about actual formal family therapy, but that's not true if we're just talking about engaging with a CSO, getting a release and bringing someone in to talk about medications, or to talk about the treatment that you're going to be providing with them, or to even just talk about basics of scheduling, letting them be involved in their care at whatever level is comfortable for the patient. We're all qualified to do that. So think, sort of challenging some of those beliefs. You don't have to be a certified, trained family therapist to engage with CSOs. Belief that the client shouldn't involve family out of fear or shame. And even a lot of our regulation supports this, that it should be a secret that patients have a substance use disorder. And I think this is really unfortunate, because the family is very aware, typically, that the substance use disorder is there. It has affected the family system. This is not a secret. But so engaging them can demystify or destigmatize a lot of stuff, can provide corrective information, and create an opportunity for some of those ruptures to start to repair. And so thinking, do I have any beliefs myself that that these patients shouldn't be connecting to anyone in their life because they're going to be stigmatized or they're going to be shamed. Believing that it would just be too difficult to manage multiple people in the room. I think that's, obviously this is an added complexity, and when we're really stressed and we're really busy, it's hard to consider, how do I coordinate those extra phone calls, or how do I coordinate making sure that these extra people show up to this appointment when it's hard enough to get the individual to the appointment. But just looking at that, maybe there are some logistical solutions that could help overcome this particular barrier. And the family not living in the area. And this is one way I think it's good to have administrative support to make sure that you have some way of doing a long distance phone call, or having like a Zoom a conversation with somebody, to be able to provide that kind of connection and support and education in the room, in the moment, with somebody that might not be able to come in person. So there's facility barriers that go along with this, not having a training for staff, having limited space. So some of us see patients in broom closets, so we don't really have a space or a group room that we can bring a family to, or multiple people to. Having limited funding for materials, like I said, for long distance phone calls, for these Zoom cameras, not allowing enough time as an organization or from administrators to support family connection. So making sure that as part of intake, that our process includes a collateral phone call. Who in their life can we reach out to just offer the opportunity to take part in this patient's treatment, and making sure that we have 20 or 30 minutes of time to do that, and that's supported, because that really is best practice, right, to be engaging with them. So now let's talk about some, just real quickly, some specific things that any of us could start to implement if you haven't already. Because we know that engaging just one person, doesn't even have to be the whole family, but just one person in that social network can be enough to strengthen the entire system, reinforce and motivate change in the individual you're working with, and help them to stay engaged in the recovery process. And I can't tell you how many times this is hugely important when we have lost of contact with somebody, when we have lost a patient, either to active use or other psychosocial barriers that have gotten away, homelessness, any number of things, they've lost their phone, to have already engaged with that CSO and be able to call them and say, hey, where is your loved one? Do you have any idea how we could get them back in? They usually know. They are much better contact than we typically are. And so that's hugely helpful for getting people back into treatment. So if you do that at the front end, you've saved yourself a lot of time, and hopefully can have an extra tool in supporting keeping people in treatment. So getting folks involved at any level could be really beneficial. talking to them about the program and recovery in general. So having like a family orientation or a family informational handout that is provided so that they can learn about what is recovery, what does that even mean. Bringing them into the intake process or the treatment planning process can be hugely important. So again, like even thinking about like a 15 or 20-minute phone call when you do that initial intake, how can you engage somebody? How can you get the release at that juncture so that you have it there when and if you need it? Sharing the learning process. So even going through some of the lessons. So we'll oftentimes do like a CBT, like functional analysis or something with a patient, then we'll bring in their CSO, we'll teach them how to do it too. So then they also have the skill. They can not only apply it to their life and maybe the substances that they're using, but then they can support their loved one when they're trying to remember how to do it when they get home. Encouraging and supporting them in a gentle, non-judgmental manner is also really important. Even if you know that this is a very unhealthy family system, what you're doing is keeping a door open to engage those folks and maybe help them get help themselves. So here are some this is just information about the studies that treatment engagement overall is improved 64 to 74% depending on the intervention when we engage with at least one person. Better retention and treatment completion as high as 77% across studies, so that's really significant. Improved family functioning, problem solving, and there are multiple evidence-based treatments that really endorse and actually require CSO involvement, CRAFT being one. There are multiple CBT and IPT interventions that include it. The Matrix has a required family component, multi-systemic family therapy, brief strategic family therapy. And I just want to highlight this Beyond Addiction book right here. At a minimum, being able to provide copies of this book to family members or to your identified patient to give to their family member can be hugely helpful. It's called How Science and Kindness Help People Change. It is a guide for families. It is all the information about CRAFT, CBT, general addiction, and it is hugely helpful for folks to understand the person that they love better, what they're going through, and how to support them without being shaming or punishing. So ways that you can encourage general CSO involvement, have a list of family therapy referrals that you can provide to your patient or to their CSO when they come in. Make sure that you recommend individual therapy. Like I said, if it's a really unhealthy system, all those individuals might need access. So even having individual therapy referral resources to be able to send those to those folks. Providing psychoeducation workshops for families. So like I said, making part of your standard of care a family orientation. So at a minimum, when somebody starts treatment, they bring in their CSO and that person gets to know about, hey, what does treatment include? What does this look like? Let's talk about different medications. Let's talk about different options so that they have that information, and also provide them with some Narcan training, because that can be a really great resource to tap into. Making sure that again, you have lists of support groups for family members. NAMI offers one. They're usually, and that's usually online, so you don't even have to have it in your local community that they can connect with. Offering to tour your facility, offering to invite them to the first appointment, offering a direct phone line that they can call somebody to get information. And then asking to see if local businesses could donate prizes, or if staff want to come up with a prize, because sometimes even just having like a gift basket that people can win in a raffle because they came to one of those orientation groups can be just a little carrot to get people in the door. Other things to think about, oftentimes CSOs work. So making sure that we have offerings in the evenings or on weekends to accommodate working schedules or working families. Making sure that your facility is sort of not just trauma informed, but also that there's a family atmosphere. So like at ASAP, we always have toys and coloring books and things available for people that bring in their kids, that we try to make it family friendly so that it's not just this sort of forensic environment. Working again to help them understand both what their experience has been, but also their loved one's experience, and letting the family know that we want them to be included, that it's going to be really hard for this individual to get better without everybody's involvement. So making sure that they understand they are part of this treatment team if they want to be, and they can make a really big difference. That being said, we also have to respect when families say, no, I can't be involved at this time, or maybe that bridge has just been so badly damaged, they need a little space. And then seeing, can we call you again later? Or would you consider letting us know when and if you change your mind? Really try to not label families as resistant or codependent or enabling. That language is really out of date, and it is not helpful both for the families, it is not helpful for the individual we're treating, and it's not helpful for us because we're going to bring some of that negative stuff into the room when we're talking with them. And these family systems are really complicated, so those labels are wholly inadequate to really describe what has happened up until this point. Thinking about how we can teach and collaborate with them rather than label them, and then being patient and flexible. So some factors to think about is ways that we can engage with CSOs to improve health, to improve stability of the home, to talk with them about how can you support meaning making, so what's going to give you a reason to actually get out of bed in the morning, and community engagement. What would that look like, whether that's with churches or volunteering? So these are all factors that dramatically influence recovery, and CSOs can have a big impact with this stuff. So that's all I got. Who has questions?